First of all, I would like to thank Professor Suresh Kumar for giving me an opportunity to share with you the talk on interpreting retinal OCT. So what is an OCT? OCT is basically something, so it's a tool which gives us a in vivo cross-sectional images of the retina which resemble histological sections, and it basically is a machine which captures the interference pattern between the light which is back scattered reflected back from the surface of retina, and there is a reference image. So and they generate an image. So the OCT has evolved over a period of time. So there were various wavelengths used. Earlier we had the initial one was the time domain OCT, the resolution was less. Then came the spectral domain OCT, resolution is good, and now the latest is the swept source OCT. So the important thing is all of them give us detail, but the resolution is different, and the swept source OCT also helps us to study the choroid in detail, and we can also in a limited way study the choroid even on the spectral domain OCT. So we can choose various protocols when we are doing OCT. We have the macular cube, so we have radial line scans which we can do, or we can have these parallel lines which we call as the raster line scans. So how will the retina look like on an OCT? So if we want to remember, so we have various layers, like these are the hyperrefractive layers. So hyperreflective layers can be the nerve fiber layer, then the inner plexiform layer, and the outer plexiform layer. So these are the hyperreflective layers, and we have the hyperreflective lines. So this is the external lipidic membrane. So this is the ellipsoid zone, earlier called as ISOS junction, and this is the retinal pigment epithelium, or the RPE. And we have the hyporeflective zones. The first one is the ganglion cell layer. We have the inner nuclear layer and the outer nuclear layer. So this is how we visualize the retina on OCT. So the OCT also helps us in giving the thickness of the retina at various points. So usually most of the machines, the first reference lines is the internal limiting membrane, ILM, and the outer reference line is the retinal pigment epithelium. So from this we can calculate the thickness of retina at various points. We also have a caliper function which can help us in determining the thickness of retina at various points. So what is important? So this is an image of a radial radial scan, and we have the ETDRS grid which is superimposed on it, and so we have kind of 9 zones which are there. And what is important is that this central 1 millimeter diameter zone, so which we call as the central subfield zone, and the mean thickness of retina in this central subfield zone is the machine takes into account. So that is called as the central subfield thickness. So in most of the studies we see this being reported. So we can overlay this ETDRS grid over the fundus image also. Our machine does take a color fundus image, so we can know the retinal thickness in various quadrants, and as well as we can overlay this color map. So the warm colors like this reddish color, it will tell us or the whitish color will tell us the retinal thickness is more in these areas, and greenish means the retinal thickness is normal in these areas. So here we can pinpoint the area of retinal thickening. So we can also generate a report. We can see the 12 scans in all the 360 degree. We can have 12 scans, and we can have the report of the scans. So I will just give you an overview of various pathologies where we use the OCT. So in diabetic macular edema we can have various patterns. The most common is the diffuse retinal thickening, and this is the one which usually will best respond to treatment, early treatment. Then we can have a pattern which we call as cystoid macular edema, so which is basically due to the fluid in well defined spaces in the outer plexiform layer. So the third pattern can be we have this this thing. So this is a subfoveal serous retinal detachment, and it is more common if renal function is compromised. If patient has nephropathy, then you have more often this kind of a pattern. And sometimes we have tractional element over the surface of retina. So this is a kind of a taut posterior hyaloid membrane causing macular edema. So these are the basic patterns of macular edema in diabetic retinopathy which we see. And if we have prominent hard exudates, they will be seen as hyperreflective dots on the OCT. So what do you mean by central involving diabetic macular edema? Central involving diabetic macular edema like this, it means that the macular edema, the major component is involving the central subfield zone, which is 1 millimeter in diameter. So this is kind of a central involving diabetic macular edema. So we can have a macular edema which is away from the center, that is non-center involving diabetic macular edema, away from the central 1 millimeter zone. So this is now. So coming on to the age-latent macular degeneration, first the dry age-latent macular degeneration. So here we are seeing drusen's. Drusen's are kind of small excrescences which we are seeing, small elevations which we are seeing here. And sometimes the drusen's, so they can coalesce, and we have a drusenoid pigment epithelial detachment. In this patient, we see that there are a number of drusen's. So they are kind of collected together to form a drusenoid pigment epithelial detachment. So another thing can be advanced dry AMD. We have this atrophy of the retina. The whole retina has become thinned out, and we can't really see the outer layers of the retina here. So this is geographic atrophy of the retina. So in wet AMD, what is important to see? So often we have a fibrovascular pigment epithelial detachment, and we have subretinal fluid, so which is seen here and here also, and this is a pigment epithelial detachment. So associated with wet AMD or CNVM, we can have this kind of thing which we call as SHREM or subretinal hyperreflective material. So sometimes it can be present, and this is present above the surface of the RPE, and sometimes it will respond to anti-VEGF treatment. And in late AMD, late wet AMD, so we can have this kind of a fibrous scar tissue formation along with cystic changes in the retina. So even if we give intravitreal injections, so the cystic changes may disappear, but this scar tissue is going to remain. Now other variant of AMD is polypoidal choroidal vasculopathy. So if we are seeing a pigment epithelial detachment which is like a thumb shaped or peaked, it's like a sharp peak along with a notch, so and along with subretinal fluid which is here, so this is called as a polypoidal choroidal vasculopathy. So we can have other features. We can have a sub-PED, a ring-like lesion here, or we can have this undulating kind of a RP line which is separate from the Bruch's membrane line. So this is called as a double layer sign. So these are all the features of polypoidal choroidal vasculopathy. So other thing to look is the vitromacular interface is also very important. The interface between the vitreous and the retina. So we can have vitromacular adhesion, which is the elevation of cortical vitreous above the retinal surface, with vitreous remaining attached within a 3 millimeter radius of the fovea. So this is called as a vitromacular adhesion. So this is the posterior layer of vitreous which is still attached to the central 3 millimeter zone of the fovea. So if there is an elevation of the retina, traction of retina along with cystic changes, we label it as vitromacular traction. So which can be broad vitromacular traction, or which can have a focal attachment called as a focal vitromacular traction. And if this traction increases, so this can finally result in formation of a macular hole. So this is a full thickness macular hole. So this is comes after the stage of vitromacular traction. So which can be again classified as small, medium and large. And we have the caliper tool here which can measure the basal diameter of the macular hole. So from that we can classify the hole as a small, medium or large macular hole. So in branch vein occlusions, so this is a case with superior branch vein occlusion. So we are seeing this cystoid macular edema, which is like, you know, more prominent towards just one side. And in CRV or central retinal vein occlusion, the macular edema, the cystoid changes will be more symmetrically distributed towards the center. So in CSR, we can have a neurosensitive detachment, we can have subretinal fibrin associated with it, or in chronic CSR, we can even see cystoid changes. So what is important that whenever we are treating patient for any pathology, so we just measure the change in the central subfield thickness, and it is also important to look at the various layers of the retina. So like this is a patient of diabetic retinopathy receiving intravitreal anti-VEGF injections. So earlier the central subfield thickness was 350 microns. After treatment, it gets reduced to 185 microns. So this is one of the parameters which also decides the change in the visual acuity. So however, now this is a patient who was treated for CRV on the left eye, and the vision did not improve beyond 636. So apparently the OCT looks normal. So what is wrong here? The wrong here is that if you closely look, the inner retinal layers in the normal eye, and if you compare this one with this one, so you will see that a lot of these inner layers of the retina are missing. So that is the cause of poor vision. So this is called as disorganization of retinal inner layers. So other thing to look is, this is again a patient with treated diabetic macular edema. The vision is 624, does not improve beyond that. So if we see that, if we see the outer layers of the retina, they are kind of missing. We don't see the, you know, ELM or the ellipsoid zone that well. So that is why the vision is not improving beyond 624. So to summarize, so we should know what is the indication of OCT, which scan protocol to choose, if the scan which you are getting is of good quality. So we can use the overlay and grid maps. So we should learn to evaluate each layer from the vitreomacular interface, the inner layers as well as outer layers, and also the choroid. And we can classify the abnormalities into one of the following, that is change in color, thickness, change in reflectivity, loss of tissue, or presence of abnormal tissue. And we can take thickness measurements, and we can identify biomarkers like I have shown drill, or the integrity of the outer retinal layers. Yeah. Yeah. Yeah.
For when we do an OCT disc, how would we know if it is a good reading, or if
What?
OCT disc?
OCT disc.
Yes.
Yeah.
How do you know the quality of the scan is good or not?
Quality of the scan. Okay. The quality of the scan, there is a function which we call as the averaging success. In the OCT, even when we are doing the OCT or when we are getting the scan, so there is a tool which we call as the averaging success rate. So my computer is disconnected. So the averaging success rate will show us, like in our machine, it will show 1 out of 4, 2 out of 4, 3 out of 4, or 4 out of 4. So if it is 4 out of 4, it means the image is quite good. It won't be grainy. The resolution will be good. If it is 1 out of 4, the image will be grainy. So the machine can itself tell you that whether it has been able to clearly pick up the scans or not. So we can know from the machine itself.
Thank you.
Thank you, Dr. Gaurav.